we have got the master of the teaching, Professor Mathew, Cherian. He'll talk about, again, challenging access and innovations in crossing hostile aneurysms. Yeah.
Honestly, for me, it's such a pleasure seeing Dr. Mehta. Many, many years back, when we were just starting to coil, my sister-in-law had an ACOM aneurysm, and I was astounded at the fact that they were so minimally invasive. It was terrifying. She had no visible scar. She had nothing. I mean, he did it under the hairline. She came out with nothing, and within 2 days, she was back into the room. So sometimes we think we are so fortunate we don't have such brilliant surgeons all over the country. But I think Dr. Mehta is one of the greatest vascular surgeons this country has. I don't know if you realize it. And the many, many people who trained under him, I think, have been so fortunate. So thank you once again for that. So today, thank you so much. Yeah. Great teachers are very hard to find. So today, so the next talk I'm going to give you is how do we cross a difficult aneurysm. You know what? If you do not know how to do this, every aneurysm is difficult to cross. So let me assure you, difficulty is a very relative term. What would be difficult for someone may not be. So I enjoy making my presentations look a little bit like art. So difficult angles are always difficult for everyone, right? Okay. Now these are some of my favorite tricks. Some of them I discovered on the way. Some of them were told by people to me, right? The problem comes in when you have a large aneurysm, which you also, how do we cross it, right? So you look at this is a crazy aneurysm by every standards, right? And you would say, how do I cross this aneurysm? I was just telling Vincent, maybe I never used a web, never dared to use a web for the fact that, it's another 7 lakh device. So unless the company makes a non-detachable web that could be reused forever, it would be a good idea. So let's show you how this works. The first thing, you take your catheter here and do not try to cross it directly. It's never going to happen. So don't even try it. It's an absolute waste of time and totally ridiculous. So take a wire. Take a soft wire because it's going to fold inside. And I generally, very often use a Traxxas, but a soft Traxxas, but you can use a Synchro, but provided it's an unruptured aneurysm. So what happens is the wire takes this loop, and finally it will find its way out as you twist and tog at this point when you have got this perfect working angle. So as you tog and push, you'll get this way out. So that's fine. Then, can you see the blue line? Is it visible? That's the micro. You take the micro up and up. So when you take a 2/7 micro catheter, sometimes it may be difficult, sometimes may be easy. So if it doesn't go, you have to take a standard like a headweight, which would go much better than a headweight 17, is fine. But the challenge is what Sukalyan was talking. How do I straighten this loop? Just pull the wire out. That's how you straighten the loop. One day I was struggling with this and Dodi was standing behind my back. He said, just pull out the wire. I said, as simple as that. It is as simple as that. If you pull the wire out and your micro is in a distal position, the micro will not fall back. It's a fundamental. If you don't know that fundamental, you will struggle and you'll struggle and you'll struggle. So remember this fact, softer the catheter, the easier to track, softer the catheter, it will never fall back. Have you got that? It's a fundamental. That's why I said, if your fundamentals are right, difficult aneurysms are seriously not difficult. So we have not had a single aneurysm we have not crossed. I'm not saying my numbers are in thousands, but it finally will go. And this is a simple maneuver. Remember this always. If it doesn't work, you can try something else. Here it is. And this is exactly the maneuver that Vincent was saying. When possible, take your Cat 5 across. I'm saying Cat 5, Sophia 5, any of those. And if you do that, you're very stable. You can do, because you want to oppose And if you're going to push hard on the FD in the neck, the FD won't oppose, it will buckle into the aneurysm and you will have a problem. Okay? So I hope you can see this. This is finally the procedure we did. Very well done. Now, how do you take a micro across a very bad tortuous distal vessel? So most of them, unfortunately, look like this. And you want to take this across this, right? But the problem what happens is, when you try to do this, this happens. No, it looked very easy before, and this happens even when you take a 1/7 micro. You know, and there was this case once, so if you get a synchro extra support, it can sometimes be a miracle. But a synchro extra support is also a dangerous wire. It's got a habit to whip forward, and sometimes you can perforate, but sometimes this can work, and you may be able to take it across, and again, pull back the wire, it will straighten. Look at this, terrible looking vessel, a crazy artery, but the end of it, you see, we are trying with something else, it was not going, and then we'll show you how it would. So this is actually stacks of images, which is a lot more realistic. It's just not happening, we couldn't get even a tog on it, and this is with the synchro extra support, where it totally behaves so radically differently, and we could cross. And you can also see there's a little bit of a step there, and by pushing on the extra support, you can actually take this across. Okay, and there it goes, okay, fine. That is it. Finally you do the treatment, and you got this, and it's fine. Okay. This is just, of course, the same thing you saw, how you do it, the push-pulls, and you got this done, and it's fine. Okay. Okay. How do you take a micro across close to a hairpin bend? Again, a very similar situation. You try to take it, it keeps kicking back. Over and over again, this happens. And then we discovered a very simple thing. So, in sheer frustration, we tried with the SC27, we tried with the headway, we tried with the extra step, it is not working. We just gave a curve to the micro. It is amazing the way it moved up. Unfortunately, I don't have the recording, I think, I'm not sure, but it seriously just went like a dream, you know. So I don't know, yeah, this is the one. You can see the bend. Can you see how tight that bend is? It's so insanely tight that sometimes it just will not take that bend. It keeps buckling all over the place, right? So remember this very simple technique, and I found it astounding by just giving it a curve which is like a C, and it just tracks across, and it just goes. So 3 points he asked, I gave you 3 points. Getting beyond the curve is possible, and most of the time, if you got those fundamental rights. Thank you.
Anybody has any questions? Any comments? Vipul?
I don't know, I've been talking a lot, so again, crossing techniques and with animations, I mean, you've covered quite a bit, and anything, Vincent, Tufel, anybody in the audience?
I have to say, recently I failed in a very large carotid ophthalmic artery aneurysm in a lady who had presented symptomatic, and she was young, and I started the case at 9 o'clock in the night, 8 or 9 o'clock in the night, and wasn't a good thing to do. I tried, I managed to get across eventually with a 17 catheter, and I didn't want to atlas it because I wanted to exchange, because it was a giant, super giant ICA. So at 1 o'clock in the morning, I gave up. So it was 1 o'clock in the morning. And I actually had a little bit of trouble here and there, but I'll stop. I should have probably put a baby Leo or something. A baby Leo would have been too small, so I didn't want to do it. So I decided to leave it, speak to the neurosurgeons, and there was a possibility whether they wanted to clip it. And on Monday morning, on table, She went on table, she was unruptured, symptomatic. On Monday morning, she just went on the table, anesthetist was going to put her to sleep. She ruptured on the table before, and she died on the table. So I learned my lesson, and I don't know whether at 1 o'clock in the morning I could have carried on further, but I couldn't cross. I tried everything, looping. So I think my mistake was on that day, it was the 5th case, but it was an elective patient who had come in as a and I bumped her from another elective case, and I think starting at 9 o'clock in the night was probably, I was already on my 5th case, and I was tired, and it was in London, so I was going to go back. I'd missed my train, I'd missed everything. And I think starting cases like this so late in the night itself, I think, is a big problem.
I absolutely agree with you, Tufel. I mean, a lot of times, my major complication when I look back, you start a difficult case late afternoon, you start struggling with it, what has been done? And intervention is very funny this way, it's micro-invasive, but it needs very fine control, very alert mind. And I think it does make a difference to start cases late, but what you faced, sometimes you feel you can cross it, it will work well, but all of us get stuck. And aneurysm is a deadly disease.
I mean, just a point for many people who are young, I think you get into this complex that you can achieve everything, and you get into this complex that you are invincible, and one day the aneurysm that aneurysm recently brought me down to ground, that I should not have started a supergiant cortico-ophthalmic 9 o'clock in the night.
So that happens. And thanks for sharing. Only when you share this real life situation, we realize how tricky handling these patients can be.
People,
so I will just quickly.
I have a comment. Arvind.
Yeah, please, sorry.
No, all this while what we look at is the anatomy, that there is a curve and all. What we are not concentrating is also on the hemodynamic. What I do sometimes is, I arrest the flow proximally and try to cross it. It will just cross.
So I'm very happy you mentioned it, because I was going to show some crossing techniques, but doesn't include the flow arrest, which does work at times. So let me go back to the very basics as well. Some of this has been covered, but I quickly go over some slides in few minutes of crossing techniques. We have seen web-based crossing technique, microcatheter shaping crossing technique, solitaire-based, and as Arvind really mentioned, flow arrest does work at times, because the wire is not going in the right direction, but the flow is taking the other way, or the microcatheter flow arrest does help. So let me go over some of my old cases. Looks like a very straightforward crossing of a basilar giant aneurysm, but whatever we could do, we couldn't. In that era, we were crossing with a balloon. That one of the technique was, and you take a loop across, and then you inflate the balloon and straighten it, and then you change it and place your microcatheter followed by a stent or a flow diverter placement. So this was the older technique when we used to use balloon to cross. Another is microcatheter straightening with wire. Again, a large paraclinoidal aneurysm. These are the ones which are difficult to cross. It keeps going in, but at times, and we crossed it a bit, but the microcatheter just wouldn't track beyond this degree. It will bulge into the aneurysm. Sometimes wire may go across, and beyond a limit, here you can see microcatheter was getting stuck. So we had to go through the aneurysm. But sometimes when you go through the aneurysm like this, so there's a way that you are going from here to here, and sometimes the catheter has gone from this to this. Sometimes you can just straighten it just like that. So this is what we did. This is a 2.7 micro. We went in, and when we went distally, all I had to do is keep the wire in the middle of something around here and just pull back gently, and we could just straighten it. So have this in mind. Once I've gone in this direction, then we need not do any extra. Okay, we could have deployed solitaire, other things. Sometimes you can just straighten it just like that. This is just another way of getting across. And then of course we could straighten it, and that's the flow diverter, and we could get ahead with the placement of the flow diverter. I think Kalyan showed this very, very well of straightening through a solitaire. Just another case, again a large cavernous. It looks like very easy to cross, but sometimes direction of the flow is such that it doesn't. Maybe flow arrest would have helped, just as Arvind mentioned recently. Again, we went through the aneurysm, and once you've gone across, we are deployed. In this case, we use a 4 millimeter solitaire, and you deploy and you straighten the system using the solitaire and to get across it. and that's a solid at another angle. You deploy partially, just part of it, and just pull back gently, and one can straighten the catheter and then go ahead with the flow diverter placement in such a situation. Sometimes your wire goes across, your mitral going across, but the ledge effect is that it gets caught at the edge of the aneurysm. In fact, I think this was the second pipeline done in North India. When Dr. Bukadi had come, we were starting this program of flow diverter when I was in Vedanta. Again, it's an IC aneurysm. Our wire crossed easily, but microcatheter was getting stuck here. Whatever we could do, we could use a stiff wire, anything. So nowadays we don't have to use this pretty often, but we use 2 wires into the system. So with a Traxxas in 14 wire, you can push in an 08 wire like a Mirage or even a hybrid. And so we placed 2 wires, and then the microcatheter tracked across because it just straightens the catheter. So sometimes you can use, nowadays we even use synchro stiff wire at times, okay? You can use that, that's a very nice wire, or sometimes you can place 2 wires through the microcatheter so that it tracks across the aneurysm, and then the flow diverter placement was pretty straightforward, and this was the, so very quickly I tried to cover using balloon, microcatheter straightening, you can use a solitaire, you can use 2 wires, and of course we have got the web technique, and we have got a flow arrest technique, and we have got microcatheter shaping techniques covered by all the faculties in this session. So, you know, so I think, and I'm sure one of the youngsters will come up with a newer technique in the next meeting as well. Younger guys are pretty innovative, and that will happen. Yeah.
Just one point, there is startup company doing steerable wire, and maybe all this will be forgotten after those guide wire with us. So, I mean, you can shape the wire with an handle, so you can completely go in any direction, even if you don't have all a position. So it's coming. Asteria is a company, Switzerland company is making those wire. Now not on the market, but it's really impressive. So maybe it will become even more simple, even if it's complex in these tricky cases.
And I think one more thing, we pull bended catheter.
Yeah, bended catheters.
It's also pretty good, and it will, you can
Yeah.
bend it around, and I think
It is a steerable tip, that means from outside you can change the tip direction of the microcatheter. No, bended catheter is not yet available, but in future that will be great in crossing this aneurysm. Technology is really helping us.
Can you teach me about this flow arrest catheter that you
I
told?
have never done it, but people mention it does work.
So how does it work? Because I've never done that.
What we do is, usually I take a coronary balloon, or this one 4 by 20. I arrest the flow proximally in the ICA.
Right.
And through that, by the side of that, I take a microcatheter and take it.
And you think that works?
Yeah, it works.
Okay.
Great. Okay, so I think we'll close this session. Thanks a lot to the chairpersons, Amit Tufail. Let us give him a nice clapping. He has been with us for the last 4 days and ever active participant.